The purpose of this video is to provide general information and education about the care of a critically ill child. It is in no way a substitute for the independent decision-making and judgment by a qualified healthcare professional. The information contained in this video should not be used to make a diagnosis or to overrule the advice of a qualified healthcare provider, nor should it be used to provide advice for emergency medical treatment. Common Pediatric Respiratory Problems by Dr. Monica Kleinman. Please note that in this video we will be following the guidelines used at Boston Children's Hospital. Some of this information may need to be modified based on the equipment, guidelines, and practices in place in your institution.
Hello, my name is Monica Kleinman. I'm an attending physician in the Medical Surgical Intensive Care Unit at Children's Hospital Boston. And today I'm going to be talking to you about common respiratory problems that children can present with.
Upper airway obstruction.
Two of the most common respiratory problems that children can present with are upper and lower airway obstruction. Now there's a whole set of conditions that can result in upper airway obstruction, but what they all have in common is typically some edema of the soft tissues of the upper airway, either in the subglottic region, below the vocal cords, or in the soft tissues above that, such as the epiglottis or hypopharynx. When you have obstruction in the upper airway, you'll demonstrate increased work of breathing because you're trying to use your muscles to draw in air against a higher resistance than normal, remembering that the pediatric airway is already fairly small in caliber. With upper airway obstruction, you'll typically see suprasternal retractions or potentially sternal retractions as well in a young infant with a compliant sternum. And there's a characteristic noise that may accompany this called stridor. And stridor is a high-pitched noise that occurs on inspiration and is the noise essentially of the turbulent airflow that the infant is generating by drawing air in through a narrowed area. If the infant has obstruction at a higher level, for instance, swelling of the tongue or excessive secretions or poor muscle tone resulting in hypopharyngeal obstruction, the sounds that may be produced are much coarser, sounds that are called stertor, for instance, which sounds more like a snoring or a rattling type of respiration. This can be easily distinguished from stridor if the baby responds to a jaw thrust maneuver, where when you relieve the upper airway obstruction from soft tissue, the noise improves. Subglottic edema won't have that same characteristic and needs other forms of treatment, such as inhaled therapy with racemic epinephrine. Upper airway obstruction is clearly one of the most dramatic presentations that a child can appear with, and can be very frightening to the child, the family, and the provider. It is important to recognize a couple of types of upper airway obstruction that require urgent and specific management. And one of those is epiglottitis. Now, we already talked about subglottic edema. Subglottic edema is the characteristic finding in croup, where one has inspiratory stridor and a barking type of cough associated with upper respiratory infection symptoms and low-grade fever. Epiglottitis presents typically in a more fulminant way, where a child is well in the morning and by afternoon has a high fever, appears toxic, and develops significant signs of upper airway obstruction that include perhaps some noisiness on inspiration because of the soft tissue swelling of the epiglottis and the surrounding tissues, but is also characterized by the child's refusal to speak or swallow because of the pain that they have in their throat. And those children will typically be drooling. If they are able to verbalize at all, they have what's described as a hot potato voice, where they're talking as though they're mouth is containing something extremely hot that alters their speech pattern. And they may adopt a characteristic position that's designed to elongate and help open the upper airway, which is called tripoding. And in tripoding, the child sits with the arms forward, leaning forward with the neck extended in an effort to further open the airway. Epiglottitis can rapidly progress to complete airway obstruction and cardiac arrest. And so it's essential, if you see this pattern, to very early on obtain expert airway help, typically from someone with training and experience in anesthesia, and possibly someone with the capability to do a surgical airway, like an emergency tracheostomy in the event that the patient cannot be intubated. These children are also very anxious, and stressing them further could precipitate worsening obstruction. And so in most cases, it's best to avoid other forms of stress, such as starting IVs or trying to position them in a way that, that you would like. Let them stay in the position they want to be with family members while you gather your expert team.
Lower airway obstruction.
Lower airway obstruction is characterized by wheezing, which can sometimes be heard without a stethoscope, but is more characteristically heard on auscultation. And with lower airway obstruction, you have delayed emptying of lung units, typically from high resistance in the lower airways, which may be caused by infection, bronchospasm, reaction to an allergen, or some other type of hypersensitivity reaction that leads to narrowing of the airways that are inside the chest as opposed to outside the chest. These infants also have a forced expiratory phase and may demonstrate seesaw type of respirations. And characteristically, when you listen, you will hear a prolonged expiratory phase where there may still be sounds of wheezing and exhalation almost up until the time the baby takes another breath. These patients still breathe fast, even though by slowing down their respiratory rate, they might allow more time for exhalation and have less air trapping. But again, when you have poor lung compliance, which occurs at high lung volumes, the baby's most efficient way to compensate is going to be to breathe quickly. And so an infant, even one with very significant wheezing, is still likely to be tachypnic as opposed to having a slower respiratory rate.
Pneumothorax.
Finally, I want to talk about an unusual condition, but one that, again, has a characteristic pattern in an infant, and that is a situation of pneumothorax. Pneumothorax occurs when there's air in the pleural space between the lung and the chest wall. In an infant, the most common time we would see a pneumothorax would typically be as a result of a pulmonary infection and mechanical ventilation, where there would be some sort of inflammation of the lung and applied trauma to the lung in the form of air under pressure that could result in leakage of air out of the lung parenchyma. This can sometimes be spontaneously seen in certain lung diseases like pneumocystis, or in certain pneumonias where there's a particular necrotizing pattern, such as methicillin-resistant Staph aureus pneumonia. It can be the result of trauma, and so a patient who's sustained a chest injury may suffer a pneumothorax because of increased pressure applied to the focal area of the lung that essentially erupts and releases air into the pleural space. Now, pneumothorax may lead to asymmetry of the chest rise and asymmetric breath sounds. One of the reasons it's important to auscultate laterally on an infant is that there can be transmission of breath sounds if one only listens apically. And to hear true asymmetry, you want to get as lateral as you can. You may also observe differential chest rise, but the real hallmark if the pneumothorax is continuing to accumulate is that there will be air under pressure in the chest, known as a tension pneumothorax. And when that occurs, the infant will fairly rapidly deteriorate with not just respiratory distress, but inadequate cardiac output. And so there will be signs of venous congestion, like distended neck veins, because blood has trouble getting into the chest, and then hypotension and poor perfusion because the heart isn't filling and therefore not ejecting. So a tension pneumothorax is a true emergency that has to be treated with decompression of the pleural space. But recognizing it early may help you to treat it in a more controlled fashion and also prevent the progression to cardiac arrest.
That concludes our video on common pediatric respiratory problems. Thank you. Please help us improve the content by providing us with some feedback. What did or didn't you like about this video? Was the content too simple, just right, or too difficult? Was the length too short, just right, or too long? Any additional comments? You can either click the Start a New Discussion button and type in feedback, or send us an email at openpediatrics@childrens.harvard.edu. Note, feedback is not required to complete this activity in the guided learning pathway.